Hello.
Hi, Dr. Obidi. How are you?
I am fine, thank you, Dr. Mehra. It's nice to be here with you. Thank you for
Yes,
having
it's
me on.
great to see you. Great to see you again.
Same here.
Um, Thanks so much for joining me today.
Sure.
Uh,
Glad to be on. How are you
uh,
doing today?
Good. I just wanted our listeners to know a little bit about you. So if you could just tell us, I know you're located in Maryland in general pediatrics, but if you could tell us a little bit about you and your
Sure.
practice. You're our neighbor, so I'm in Virginia. Um,
Absolutely. Yes.
yeah.
So I am in Maryland, Western Maryland, and so my practice is actually in Hagerstown, Maryland, and I've been at this location for like over 17
Okay.
years. Um, father of three, married to my lovely wife, and I'm a general pediatrician, board certified, and just been practicing out here for the longest.
Okay, great. And so you see pediatric patients like babies to 18, or what's the
Yeah.
age
So
range?
I I actually see from zero babies, newborns to about 20 to 23 years of age.
Okay.
I do have a family practice, so I have some nurse practitioners who see adults as well. So they see, to kind of transition them onto the nurse practitioners when they're over 20, 22 years old.
Okay. Okay, great. And so you've been seeing pediatric patients since for the last 17 years in Maryland, is that right?
Yeah, that's
Okay.
correct.
Okay, great. So I wanted to just talk to you a little bit today about what your patients could expect when they see you at their well child visits,
Mhm.
specifically for weight. Like,
Yeah.
how do you approach that? And when do you actually start having that discussion
Yeah.
with the parents?
Sure, sure. I mean, one of the wonderful things about pediatrics is just the fact that you get to track these kids over a period of time, right? I mean,
Mhm.
that's one of the beautiful things about being in general pediatrics. And as part of that relationship with families, we're seeing them for these well child exams that we schedule pretty, they're spaced out over several months and certainly yearly after a period of time.
Uh-huh.
So we see them at birth, and then there's the 1 month well child, the 2 month, 4 months, six
Mhm.
months, 9 months, 12 months, and then it's 6 months after that to 18 months. 15 months and 18 months, 2 years, 2.5 years, and then 3 years and yearly after that,
Okay.
So we get to see them at all these points. And one of the things you do during a well child exam is to take a look at growth.
Hmm.
And that's where the growth chart is our dear friend, because we can track a kid's weight and height over a period of time
Hmm.
looking at the growth chart. And
Hmm.
that's so it's so helpful and instructive, because we can start to pick up trends to see if a child is beginning to put on weight or beginning to lose weight,
Hmm.
and that helps guide that conversation. So that really will be a conversation that can start as early as several months, like, the first year of life. If
Hmm.
we're seeing this sharp uptake, and then we had to sort of try and determine if this is, just something genetic, or where, like, for instance, breastfed babies sometimes will have this, big weight spike on the growth chart and then sort of start to level off. So we get to track over time to see what may be going on. But certainly when it looks like that growth chart is the percentiles are increasing and giving us some indication that there may be some weight issue going on, we start to have that conversation then. So it could be as early as that first year of life, or certainly, down the road at whatever point we feel there's some indication there's something going on.
Okay. And so what do you start with, or how do you have that discussion? So say you have a child and you said you start maybe at one, say you have a child that has, significant increase in their weight.
Yeah.
How do you counsel the families, or what do you
Yeah.
say?
Yeah. So I think that's also the beauty of having this sort of longitudinal practice where you follow them over a period of
Mhm.
time, because you get a chance to develop a relationship with parents and with families. And I think that's really helpful,
Mhm.
because then you're able to, how I may bring it up with one parent may be different from how I bring it up with another parent,
Mhm.
right?
Mhm.
Plus also, I I can see the whole family, and I can also see, just generally speaking, generally assess mom or dad's health and see
Mhm.
if they're also overweight or heavier than they should, than what will be for their height, which may also affect that conversation too. Because if mom or dad are obese, or well past what will be an ideal weight for them, for their body structure, that may also, I have to take that into consideration, because as I'm speaking to them about their child, they're going to internalize a lot of that also. And so you could have parents who become defensive, and not receive that information. So it just involves a lot of tact, I guess, is what I'm trying to say. We certainly address it. It's very helpful. That's why I love having a growth chart, because it's like an objective sort of tool I can use. I can look at them and say, hey, look, this is what's been going on with Johnny's weight. He's been nice and steady, and all of a sudden, look at this spike here, right?
Right.
And that just makes it easier to have that conversation, because they can also see it. Oftentimes, parents already know that their kids are overweight, right? So they know that that's the issue. And so when you bring it up, I think when you create an environment that's safe, where there isn't like a judgmental edge to your conversation, I think it's better received. Some parents even bring it up on their own. When I ask that first question, are there any concerns, today? Some parents already bring up, well, I'm concerned about the weight, right? And that's an easier conversation, because they've already brought that up.
Okay. And so, at what point do you think about, screening, or what do you do as far as screening evaluation? And when do you start that process for kids?
Yeah. So again, it starts really very in that first year of life, because we're also taking a nutrition history as well, right? So we're also saying, maybe say from 6 months to 9 months, those visits where they've started to introduce solids, we can start to ask questions, and especially as they get, past a year old, when they're beginning to eat a lot of table food, what's the diet like? And so if I'm hearing, we're giving lots of French fries, and we're giving like chicken nuggets, and we're hearing a lot of processed food and a lot of foods that would typically be, unhealthy in quantities, then I can start to have that conversation. Are we having any fruits? Are we having any veggies? What kind of milk are we giving? Maybe as part of the history, I may get a history of, they're getting like, 2-3 bottles of juice a day, right? So that's a conversation I can have then. Well, ideally, first of all, there's really no need for any juice at all to start with.
Okay.
And if you must give some juice, maybe 4 ounces.
Yeah.
So it's really starting early. I think you start to screen nutrition in conjunction with the growth chart. You can start to sort of have that conversation about weight, and about what's healthy in terms of nutrition.
Okay. And then do you give them a period of time that you're monitoring them? So say you give them that guidance, do you say come back in 3 months, 6 months?
Yeah.
What is your approach usually?
We try and stick to 3 months in the practice, because if I find out when we make it too far out, like 6 months, it sort of drops off everyone's radar. They're not as committed to trying to do whatever, follow whatever prescriptions you've come up with in terms of lifestyle changes or modifications. And so if it's 3 months is shorter, they kind of have a goal to walk towards. Sometimes even monthly, depending on how significant of a weight issue there is. And then also gives us an opportunity to see if they're actually seriously working on it and are able to do that successfully on their own, or if we need to refer to a nutritionist, for instance, to help.
Okay.
As well as, a chance to be able to judge if there's something else going on other than just nutrition and lifestyle issues, if there's some metabolic reason for the weight gain.
Yeah. And so speaking of along the lines of nutritionists, I've had a lot of families say that it's really hard to access, nutritionists, and, how often are they supposed to be seeing the nutritionist? Do you have a nutritionist in your office, or what is your approach to it?
Have one in my office. It'd be wonderful to have one in the office.
Yeah, right.
You're right. It is a difficult service to access in the area. I will say it's better now than it was, 15 years ago when I first came to, 17 years plus ago when I first came to the area. Now there are some nutritionists in the area. We have a local physical therapy place that actually has a program as well, Pediatric Movement Center, and another one that opened recently called Call Life that actually have an obesity program or weight management program attached to their offerings, which has been helpful. But yeah, I think it's still a bit of a challenge, but it's certainly better than it has been previously.
Right. So one of the questions one of the listeners has is, do you keep an eye out for diabetes? And of course, I do that.
Yeah.
But what is the age range that you typically start, screening for diabetes for children?
Yeah. So I think usually as they get into the early teen years, especially if I'm seeing a lot of weight gain, I will start to screen, and I will send a hemoglobin A1C sometimes just to see if there's a lot of weight gain and also there's a family history as well. That can be one indication or one touch point to see if I need to screen for that. But yes, usually early teen years, I would say. Now, sometimes younger, if I have a kid who is 7, 8 years old and there's a lot of weight gain, I will screen at that point as well.
Right.
But I find a lot of times it's the early teen years.
Yeah. So, when I was training many years ago, we used to always say we never see type 2 diabetes. We said that. Never see type 2 diabetes in kids younger than age 10.
Yeah.
But I'm actually seeing patients with type 2 diabetes as early as 7 or 8 now because of the weight, and especially like you said, because there's family history sometimes of diabetes. And so I think that is an important thing to keep in mind for parents also, and for pediatricians, just to make sure that we are screening, because that's something that we can treat.
That's right.
With medication. The other question I had for you is, with regards to weight, we talk a lot about overweight in pediatrics, and the other flip side to that is underweight, right?
Yeah.
And I've had a lot of controversy recently because I've told my patients not to drink juice and not to have that they don't need it. But I think I wanted to talk to you a little bit about your approach to the underweight child, because I also have a lot of families come to see me sometimes. They're not growing with regards to their height, and they're also not gaining weight with regards to just their caloric intake. Their weight's not going up, or they're losing weight, and sometimes that's related to diet. Sometimes it can be related to other things, hormonal issues. But I wanted to talk to you about that. What is your approach for that? Is it the same longitudinal, or do you screen for those patients a little bit sooner and faster?
Yeah, I think also that's also where the growth chart comes into play as well, which is very helpful, at least for me as a general pediatrician. I will tell you that maybe, I don't know, just take a stab at it. Like 90% of the time when a mom is worried about their kid being underweight, they're actually they're an appropriate weight, especially if they happen to be of ethnic origin. So they're Africans or Latinos, or I find a lot of even Asians sometimes. A lot of those moms sort of have, and I speak as I've been an African myself, moms tend to have and sort of overinflated idea of how much food we should be eating as kids, right? And you must eat all the food on your plate. And so sometimes when moms are worried or parents are worried that their kids are underweight, and I look at the growth chart, I can also show them, hey, look, we have a nice, beautiful, steady growth rate. Maybe they're 50th percentile, but that's just what they are, genetic makeup, is. So we all have different sizes, right? Even as adults, we have adults who are taller, who are shorter, different size weights. And we want to see that a child is sticking to, generally speaking, a growth percentile that seems to be appropriate for them genetically. But there are real cases where there is, underweight, where maybe they've even grown nicely for a period of time, and then we can see them trailing off on the growth chart and are beginning to lose more weight than is expected. And in those cases, again, you try and get a nutrition history. Sometimes those kids are not eating very well. Sometimes parents are not feeding enough calories, especially with the toddlers, and sometimes even babies may not be feeding enough calories. If you have a kid who is really very picky, there may be other things at play, like some maybe genetic condition where kids are just difficult to feed. A kid who's autistic, sometimes that can be difficult because they're sensitive to textures, they're sensitive to kinds of foods, and so maybe they only eat one kind of food, or only eat or only take liquids, and it's difficult to feed solids. So that becomes more challenging. I think, again, the growth chart helps us to screen for underweight cases. And then the approach is going to be individualized again as well. I mean, if you have a child who's autistic and is just refusing to eat foods because of texture, that kid is going to be someone that we refer right away to a therapist, a feeding clinic, to sort of work with them with handling textures, as opposed to someone else who's maybe just a picky eater and the parents haven't sort of, really encouraged a lot of foods or high caloric foods to help with that, with that situation. That's also different to what you advise.
Yeah. Yeah, and I think, the important piece about, because I get a lot of referrals for underweight as well as overweight, and I think the important piece from the endocrine perspective is, overweight has its own set of complications or hormonal complications, right? So, overweight can lead to early puberty in girls. It can lead to diabetes, like, we all know those issues. And in older girls, it can lead to irregular menstrual cycles or PCOS. Um, and actually can cause accelerated growth in patients who are, overweight. Underweight, though, when I see patients for underweight in my clinic or they're referred for endocrine, the first thing I look at is their height also. So if they're, decreased weight significantly and they're not growing, then that may be a hormonal issue. But if they're, usually the first thing that we see in endocrine is that their weight drops off. But if their height is maintained, usually it's not a hormonal issue. And like you said, it's more nutritional, might be more gastroenterology or artistic or things like that. But really, we look at, like you said, the growth chart from a longitudinal perspective. And I always, look at the height also, and I know you do too.
Yes.
If their height is, stable, then it's not usually a hormonal problem. So I don't know if you get a lot of those questions, but I get a lot of those questions too for, screening their thyroid because they're underweight or they're overweight. And oftentimes, it's not related to that. It's related to, what their diet is. So I think that's super important to pay attention to. You mentioned briefly about portion sizes, and do you have good guidelines that you give your patients and your parents about what the appropriate portion sizes are? Because I think there's a lot of confusion about what the right portion size is for kids. And it can lead to, like you said, underweight if they're not getting enough, overweight if they're getting, too many calories. So, and often, we don't, as parents, we don't get that education to say what is the right portion size for our kids and what should they be eating and drinking on a regular basis. And there's so much information in the media and the press about what's, healthy and not. So let's talk about portion sizes. Do you have some general guidance that you give for portions?
Yeah, I have a few charts that sort of give you general ideas of what those will look like for kids of different ages. And I also have a few charts that also talk about what caloric requirements are generally for a 7-year-old girl versus, a 14-year-old boy. And sometimes that's helpful, especially, in this sort of technology age that we're at, where there's so many apps that can actually help you calculate calories also, because I can say, that even helps with kids who are overweight as well. Say, hey, listen, this is generally speaking the amount of calories you should be taking a day, depending again on level of activity. And how about you just use your app and track how much you're actually taking? And sometimes they realize how far off they are in terms of extra calories. But I think that can be helpful also in terms of just seeing where we in terms of the number of calories we're taking in. So I think that's helpful. I think also just talking to them about on the plate itself, how much of it is proteins, how much of it is carbohydrates, how much of it is, your veggies, and just trying to see how we can help them. Say maybe half the plate veggies, and another half we can do as proteins, and then, carbs and fats. I think that's helpful. For children, especially in that first year, toddlers, I think it's a good visual sometimes to tell moms, hey, your child's stomach without any food in it is only about the size of their fist, right? So it's only so much food can actually go in there. And sometimes that really gets them thinking like, oh, actually, the stomach is that small. Really, I didn't realize that because I'm putting like all this food on the plate, making them finish all of it because we don't want to waste food, right? So I think it'd be helpful as well to give some guidance in terms of portion sizes.
Yeah, that's actually exactly what I do too. And I tell them the same thing as far as the plate, the healthy plate. I think we all learn the same type of training in residency. But the other piece that I always tell them is, and I don't know if you do the same thing, but you say, look at the child's fist, right? So we look at the
Hmm.
child's fist. And we
Hmm.
say, okay, the fist is like really the size, their fist, not
Yeah.
yours, but their fist is like the size of the
Yeah.
protein, right? And then their palm of their hand is the size of the carbs, and then the rest of the plate really is veggies or
That is,
fruit.
yeah. Hmm.
But the other question I have here is, somebody's asking about, and I don't know if you see a lot of that. I worked in Chicago, I worked in DC,
Hmm.
I worked in a lot of inner city areas, and patients used to ask me this question all the time about fruits and veggies. You say half the plate's fruits and veggies. Fruits and veggies are expensive, right? And so, we have a lot of families who say that, they say fruits and veggies are really expensive. How do we, afford to feed our kids a healthy diet? The processed food is often cheaper
Yeah.
than, unfortunately. And so I think it's, an issue with this, system. But what do you say to your families who say that to you?
Yeah. Yes, and you're right. Eating healthy can be more expensive.
Mhm.
I think though that families can still be creative. I think that when you first of all already make an effort and you've already decided I'm going to eat healthy, I think you just naturally find ways to get that done, right?
Mhm.
So maybe I might not be able to go to an organic in the supermarket, but I can go to my regular grocery store and still see what I can afford there
Mhm.
that is, a vegetable or fruit. So I think that first of all is just trying not to automatically make that be a barrier and just say, it's expensive, I can't do it. All right.
Mhm.
There are some resources in the area. I know in our local area here, there's a healthy, I think it's healthywashingtoncounty.org. There's like a program, Go for Bold is one of the programs within that program where they're trying to lose 1 million pounds, in a certain number of years. I can't remember what it is now, but within that program, there are some programs locally available. One of them, for instance, is parents could call some of their local grocery stores. One of them is Martin's and another one is Food Lion, where they can actually get a tour through the supermarket to the grocery store to teach them how to shop, right, on their budget. And I think, online, there are probably a number of resources where they can go on and just sort of see what's available given their current economic situation. I don't think it's completely impossible to still get the number of fruits and veggies you need, amount of fruits and veggies you need at a decent, reasonable price. I
Yeah.
think first of all, we just sort of automatically feel it's so expensive, so I'm not even going to try,
Right.
which
Right. Right.
that
I
doesn't happen.
agree. And I think the other part of that is, there are, frozen fruits and veggies are available also. And, that's okay to try, the frozen, and they last longer. You
Yeah.
can freeze them. You can add them, to start with, your dinners, and have, the veggies and, your protein with that piece of it. So I think that's really important. I did hear, have someone say that you can also go to the local library sometimes, and they have places that you can plant.
Yeah,
Uh,
that's yeah, yeah. And
um,
also is thinking through, if you have someone who's really motivated, they can also rearrange their budget, right? Because a lot of those families are spending some money on juice, are spending some money on chips, are spending some money on other foods that are
right.
not healthy or getting them to their goal, right? And that's
Right.
money they could peel back and spend towards getting the fruits and the veggies. So I think sometimes just looking at our priorities and where we're spending that money, we might be
Mhm.
able to reassign some of those resources to go towards just eating healthier.
Yeah. Yeah. Okay. All right. Great. This has been so wonderful. Thank you so
Yeah.
much. I know we're talking in a minute also about thyroid and overweight. So this is, the discussion today on your site. But I don't know if you have any last words that you want to say or tell people where to
Yeah.
find you one more time.
Absolutely. Just in terms of, first of all, just getting your child to healthier weight, I just want to say that, oftentimes there's a lot of shame around that. And so where there's shame, it's difficult to really make significant progress towards your goal. And so just letting parents know that there's no shame in where you found yourself. You know, your child is overweight, maybe you're also overweight. Just saying, okay, this is where we are. How do we get to where we need to get to? And just really taking the steps you can, the small steps, baby steps in the right direction. So don't give up. You know, reach out to your primary care provider, reach out to any specialist you've been referred to, whether that's a nutritionist or an endocrinologist like Dr. Mehra, and, you know, really get the guidance you need, because it's certainly possible. And again, we're out in Western Maryland, Hagerstown, Maryland. It's partners in pediatrics and family health. And we take care of both kids and adults out here, and be happy to take care of anyone in the area.
Okay, great. Thank you so much. Thank you, Dr.
Having me on.
Thank
It
you.
was fun talking.
Okay, great. Thank you. Bye.